Good morning, everyone, and welcome to the Leading Age Michigan Safe and Calm webinar for June 2nd. We're now just entering our 15th month living under pandemic conditions, but at least it seems like we have a sense of some normalcy returning, at least in some of our everyday routine life. However, we all know that the guidance is still being revised and updated on an ongoing basis, and we still have some challenges in consistency between regulatory agencies and some challenges just trying to understand the intention of some of these rules. So we're going to try and do that a little bit more today. This morning, we're going to start with our routine agenda. Dalton will be providing a brief advocacy update with a focus on the recently announced requirements for implicit bias training. We're going to follow with a quick review of the Michigan data, and then we'll go on to the new and revised regulatory provisions for residential care facilities and try to figure out what the intention of some of those are. So let's turn the presentation over to Dalton.
Good morning, everyone. I hope everyone's doing well today. As Deanna said, we'll be covering mostly the implicit bias training that the governor spoke about yesterday in a press conference. This has kind of been in the works for a while here in Lansing, but it really wasn't set in stone until the governor's announcement yesterday. So yesterday, her announcement essentially boiled down to her saying that most healthcare professionals except vets or veterinarians are going to be required to have implicit bias training in order to apply or renew their license. We'll talk about the exact impacts of that on the next slide. But generally here you can see we have a link to the public health code if you want to read the exact thing. This work was based on the work of the, I don't remember the month, but of the Racial Inequities Task Force that the governor set up early in the pandemic. I did copy exactly what implicit bias is defined as below here on the slide, so you can read it. I won't read it today, but do know that these trainings, any training that is either a webinar, an online training, or an in-person training will qualify for meeting this requirement. So what are the impacts of this? This won't go into effect until June 1st of 2022, so they're giving us a year to kind of get situated here. What the specifics are is that an individual must have complete a minimum of 1 hour training for each year of an applicant's license or registration cycle. So as a nursing home administrator, you renew every 2 years, so you will need 2 hours of implicit bias training to renew your license. This applies to both those renewing and those who are going to be new applicants for licensure. New applicants will need 2 hours of implicit bias training to apply for licensure. You should have received an email yesterday to whatever email you have on file for your license. So please feel free to check there for more detail and more specifics about the exact process of how to submit. Yes? Oh, okay. Next slide, please. So what are your responsibilities as a licensee? They're very similar to pain management or human trafficking. Essentially, you need to have a document in your CE file that says you completed the training, the 2 hours of training for nursing home administrators, et cetera, et cetera. This can either be a certificate issued by the training program or a self-attestation that the licensee or registrant attended one of the training, including some information regarding the training. So the date of the training, the program sponsor's name, the title, and then your name. You should retain this documentation for a period of at least 6 years because it's all subject to audit when you apply for licenses. I'm sure anyone who has renewed their license knows the process here. So that's kind of it for the implicit bias training. Pretty straightforward and similar to other processes, but we just wanted to touch on it a little bit this morning because the governor's announcement yesterday lacked some detail. And so I just wanted to talk about a bill, but really use this to paint kind of how the legislature and the governor are working together While the relationship has gotten better, the legislature and the governor are still kind of at odds with one another. Senate Bill 450 limits visitation restrictions. So it essentially would prohibit the director of MDHHS or a local health officer from issuing an emergency order that would prohibit a patient representative from visiting a patient in qualified health facilities, or prohibit or limit a health facility from implementing reasonable safety measures. Seems pretty straightforward, but it's being handled very politically here. And so it's very unlikely to get signed, but it is just something to note that these conversations are happening in Lansing.
All right, thank you very much, Dalton. Before we get into any questions, we did just want to let everyone know that the Leading Age Michigan Award Gala is open for submissions. And if, in case anyone does not know what that is, the Leading Age Michigan Annual Awards Gala honors those who embody excellence in leadership, care, and service innovation, and who have made outstanding contributions to their organizations in the field of aging services. The awards celebrate stories of employees, volunteers, residents, and programs that have made a significant difference in the lives of others. This is a great way to say thank you to those who go above and beyond what is expected. These awards are all about people who make a difference every day in the lives of the people they serve. It's about staff members who put quality first, deliver excellence, and inspire others to do the same. Nominations are now open, and they will be due Friday, June 11th. So we still have a couple more weeks to get those nominations in. If you haven't gotten your nominations in, you can feel free to email our Director of Professional Development, Anissa Mazuka. Her email is Anissa, and that is ANISA at leadingagemi.org, or you can go ahead and email info@leadingagemi.org, and we will make sure to get that link over to you so you can submit nominations for all of your staff. We do just have one question for you, Dalton. Does the bias training include social work staff?
Yes, it includes all licensed healthcare professionals in the state who hold a state license, except for veterinarians.
All right, that was the only question, so we can go ahead and move on.
Okay, thanks, Dalton. Let's take a quick look at the Michigan COVID data. So here, fortunately, we continue to see rather dramatic declines in the overall case rate in Michigan. And we're getting close to daily case rates as low as early summer last year. So that's really good. It's important to remember that this, go back, Blake, please. It's important to remember that this is a 7-day rolling average. So when you're looking at the last number on the far right of the slide, it really is that 7-day average. The actual number of new cases is less than that because it's on a decline. So, and that's because it's averaged over the previous week for each day. So in terms of deaths, we can also see, finally, a dramatic decrease in the 7-day average number of daily deaths as well. They're going down significantly. When we look at the CMS County positivity rates, we continue to improve, although we're still not quite at the place we were in early March. Nursing home members must remember that they have to continue to monitor these rates on a weekly basis, since facilities and counties with over 10%, or at least in the red category, must continue to do serial testing for unvaccinated staff on a twice per week basis. Michigan's long-term care caseload data is normally uploaded every Monday, but as of yesterday afternoon, it had not been yet updated for the previous week. But we do have data here as of last May 24th report date. And we really haven't seen any further declines in SNF caseload over the past several weeks, but the numbers do continue to be pretty low. One thing that we have heard from a couple sources is that there's a few groups in Michigan who believe that the SNF death case count has been significantly underreported. And that they're basing that on the fact that they're not sure that MDHHS really looked at all of the appropriate death records for potential COVID cases. But that's really just a conjecture at this point. There's no really hard data about that. But some sources have estimated that it could be underreported by quite a bit. So we'll kind of keep an eye on that and see how that plays out. The HFA caseload has declined over the past several weeks as well. And you have to remember again that we don't have the data yet for the week of May 31st. Pretty much the same is true for AFC data, although there was a small increase in the number of cases as of last week, or the week prior rather. But even so, the rate of new COVID positives has been pretty small. So these are really good reports for all three kinds of residential settings. MDHHS has several ways that it looks at the vaccination rates for Michigan. This graphic shows the overall rate for the target population aged 14 and up. Since that's a new group, 14 to 16-year-olds, that has just been added to the target population, they kind of flooded the population overall, and the overall rate for Michigan went down a bit. But we are still close to having half of the adults in Michigan, age 14 and over, being fully vaccinated. There are some other charts available that only count the number of persons who've had at least one dose, but these are the numbers of fully vaccinated persons as of yesterday. So we're going to move on to a review of the guidance, and we're going to do something kind of like we did at our last webinar. These 4 topics have been updated, or at least have had some questions over the past couple of weeks. So we're going to again review the most updated guidance for these areas. Then we're going to talk a little bit about mandating vaccines and a few other short updates. So we're going to start with masking and social distancing. This, along with communal activities, has been really confusing the past week or so, at least in the guidance for residential care facilities. So here is a summary of the current guidelines. First, again, the primary source for the rules, and at this point, most rules, is the QSO 2039NH. And that is definitely deferred to by MDHHS. And that CMS QSO document refers to the CDC document as a set of rules, and that is also linked on this slide page. So first, staff must continue to wear source control at all times whenever they're in a resident care area. So at this point, if you have office staff who are confined to non-resident care areas, masks can be eliminated if the employee is fully vaccinated only. And for meetings and breaks, masks and social distancing can be avoided when everyone in the room is fully vaccinated. Residents, though, who are fully vaccinated, they can actually choose to have close contact and no masking, but only when all are fully vaccinated and they're in a designated or private area. And this has been a major question in the previous week or so. What about the staff? What if the resident and visitor are fully vaccinated, but staff coming into and out of resident units or designated spaces are not vaccinated? The CDC and the IPRAT team have confirmed that then masks must be used for everyone and social distancing maintained. So if you have an unvaccinated staff person coming in and out of these areas, you have to do the normal or the previous safety precautions for masking and social distancing. If a resident is vaccinated, but the visitor is not, the resident can choose to have close contact, but both parties must be wearing masks at that point. So although the CDC guidance for masking and distancing in public, and this is, again, the public piece, not for healthcare facilities in particular, apparently was revised again last Friday. And we're including it here just because it seemed like to us that it provides a good graphic that's a potential tool. There really is nothing new in this guidance, but the CDC updated this graphic to align with the new flexibilities for vaccinated persons who are out in public. You can move it, Blake. So this is the graphic. And we thought it provided a great visual description of what is safe and what is not safe in public. So we were thinking it could be used as a good educational tool for residents who might be going out on outings. It also identifies the level of risk. So, I mean, obviously on the right side of the screen, there's very little risk for fully vaccinated persons. But not only does it say what the risks are for unvaccinated persons, it tells you the level of risks in some of these activities. So it's kind of good to maybe share this with residents who might be going out. So let's move on to communal activities, which is another area of confusion. The guidance for communal activities is again briefly discussed in the QSO, but then it also relies on the CDC guidance that is again linked at the top of the page. And this piece, again, a lot of questions, a lot of confusion over the past 2 weeks. Basically, we do know that anyone who's in isolation or quarantine cannot be attending any communal activities. And the CDC directly states here that facilities might find that knowing in advance of these activities, the vaccination status of residents and staff would be helpful in setting up an activity or event. So now, if all the residents are fully vaccinated, they can choose to have close contact. And that means they can play cards, they can sit closer to each other, and they don't have to wear masks. But if there is an unvaccinated resident present at all, then all the participants must wear masks. But only the unvaccinated patients and residents have to physically distance themselves. And that's an important point that we're going to talk about in a bit when we look at MDHS's take on that. So again, if there are unvaccinated residents in the room, everyone must wear a mask, but only the unvaccinated persons have to be 6 feet apart from each other and from anyone else in the room. For dining, again, if everyone is fully vaccinated in the room, no masks or distancing is required. But if there are any unvaccinated residents, then all are to use source control, which means masks, of course, when they're not eating. And again, anyone who is not vaccinated must remain at least 6 feet from everyone else. So at least one of the questions here is, again, what about the staff? What if the staff attending are unvaccinated? We know that staff are going to be moving in and out of these events and activities and rooms all of the time. You can move the slide, Blake, please. So, what about those staff? Katie Comey from MDHHS responded to that question, that since the 2 provisions that we just talked about from the CDC on the previous slide do not directly mention staff, then pretty much facilities can make a judgment and do what they want. And actually, we found that to be an interesting interpretation, considering what we normally hear from the department. The IPRAD team, however, and I have to kind of agree with them in at least trying to figure out the intention of the CDC. The IPRAD team clearly found areas within several pieces of the CDC guidance that states that any time an unvaccinated staff person enters the room, then all masking and social distancing applies. And they also stated that it makes no sense to require all the precautions when unvaccinated residents are in the room, but if an unvaccinated staff member is in the room, it wouldn't matter. So that's kind of the way we are thinking CDC's intention was as well. MIOSHA responded to this question with a non-answer. They pretty much just stated that they don't cover resident rules, just the rules for the employees. So we know that there's been a lot of questions about this. We tend to agree until we hear from the CDC with the IPRAT team. We believe that their intention was that anytime an unvaccinated staff person or any other resident is in the room, then at least masking would apply. The department also has a different take on the communal activity rules that we just went through a second ago. It's different, specifically different than what is written in the CDC guidance. Their updated order from May 21st has to be carefully read because it seems like it's in complete alignment with the CDC, but it really is not. So remember that the CDC requires masking if there's any unvaccinated person in the room for any group activities, unless of course the residents are eating. You have to have a mask though, if there's any unvaccinated person in the room. But they only require that the unvaccinated be socially distanced from each other and from those who are vaccinated. The state does not allow that. They have come out and specifically said that that would segregate the non-vaccinated residents inappropriately from the rest of the groups. So MDHS is saying that if there's any unvaccinated person in the room, then all persons must mask and all persons must socially distance themselves. And that's their requirement. The link to that May 21st order is here at the bottom of the slide. So we're going to briefly review visitation. We still get some questions about this. The visitation guidance, even here in Michigan, based on the MDHS rules, relies on the QSO 2839 NH. And outdoor visitation is still considered the safest and is preferred whenever possible. Remember that visitation is always allowed for vaccinated persons unless they are in transmission-based precautions, but then they would be allowed compassionate care visits if needed. Anyone in quarantine can also have compassionate care visits. So note that CMS states that we should consider the number of visitors allowed at one time and the total in the facility. So they have made all those requirements for visitation, was a long list in the past, a lot more flexible and pretty much at the discretion of the facility in terms of what their needs are. During an outbreak, and these rules of course are not new, but you must immediately test all staff and residents. And if during the first round of testing you don't find any new positives outside of the affected area, you can open visitation to only that affected area. You can open visitation to only that unaffected area. And that applies whether or not the residents are vaccinated or unvaccinated. If you do find a case that is outside the affected area where the outbreak occurred, all visitation must cease except for compassionate care, and you have to continue your testing. So what does the state say about visitation beyond its reference to the QSO document? Basically, they're in alignment with what is in the QSO, the CMS document. Although there is a new document, relatively new, it's not brand new, it's from March, document, the March 17th Residential Care Facilities Visitation Guidance. That's still out there. And this document caused a lot of concern at first because it continued a lot of the more restrictive ideas about visitation that CMS had dropped out of its QSO language. So we pulled some of these provisions up on the page. Throughout this guidance, the department uses the word recommend. We know in some parts of the regulatory world that means that you must do something. But for this document, MDHHS has stepped back and they are calling these best practices only without any real requirement to do them beyond that which is in the QSO. And so this is where the guidance has stated that visitation should be limited to 2 persons, but that's only a recommendation and no longer a requirement. So we've updated that point in our Q&A document that we sent out after our last webinar. So now we're going to take a quick look at the current provisions for quarantine. We've included a brief summary here of the revised CDC rules for quarantine, but only because we continue to get some questions about this. It really hasn't changed in the last week or so, or 2. CMS in its QSO document does refer to the CDC guidance that's linked on this page. A reminder that if staff are fully vaccinated, they do not have to quarantine following any high-risk exposures. The statement, though, is still about travel guidance is still in effect. So the MDHHS take on that, the last we've heard, we've not gotten any updates, is that unvaccinated staff must still isolate for 14 days following any domestic or international travel. Fully vaccinated residents, though, they do have to quarantine following a prolonged close contact. And quarantine, we know, is no longer recommended for any new admission, as long as they fully vaccinated and they have not had any close contacts in the last 14 days. So this is the MDHHS quarantine guidance for residents, and there really are no surprises here. The only difference between this and the CDC document is they identify the need when quarantine might be needed after residential outings. Residents go out of the building, either for a few hours or for outings of more than 24 hours. So even if the resident is not fully vaccinated, they don't have to quarantine after a brief outing. And if the outing was over 24 hours, they have to quarantine if it's a hospital stay. But otherwise, it only depends on your screening. And the CDC still requires screening for all persons who are coming into the building, and MDHHS strongly encourages temperatures still be taken. Okay, so that's a review of the 4 main areas that we've seen confusion and had a lot of questions about in the last 2 weeks. Let's see if there's any questions.
All right, thank you, Deanna. Again, before we get into any questions, I did just want to show everybody here. Always just to take a glance at our event calendar. So once you go to our website, leadingagemi.org, you can go ahead and click on this events tab right here, and it will take you to all of our upcoming events. We have our Executive Nursing Leadership Series. That is an ongoing, you can take that at your own pace. I believe you can get up to 20 CE credits for this one as well. So I think that is a good series. If you are interested in that, go ahead and click on that. And it doesn't start the 11th. It's just going to always be on our calendar as it is an ongoing event. So we have that. We have a couple more webinars as well. We have our Liability Summit coming up July 21st. Registration is now open for that as well, and that should be a very good new series for us. And also we have our pain management that we just listed as well. So if anybody does need their pain credits or pain management credits, you can go ahead and register for that as well. And there should be some more exciting information getting posted on there in the next couple weeks as well. So watch out for that. So now let me hop into the questions. Any word on if volunteers are allowed back yet?
Yes, we have a slide about that. Volunteers are allowed back in with all of the same requirements that your staff would basically have in terms of infection control practices, testing and vaccination. There's not a whole lot more to know about that, but we do have a slide about it later in the program.
Okay. For POC test reporting, is it true that it's expected that every test must be reported within 24 hours, even on weekends, holidays, even if they are negative? POC test reporting being a 365, 7-day-a-week job seems like a ridiculous expectation.
To be honest, I have not reviewed that guidance in a while, and I would have to go back and look at it. I remember that at one point, I think the positives had to be reported within 4 hours. But don't take my word for that. I do remember that there were some documents that seemed difficult to understand, and there was some question about who they actually applied to. So we will put this question in our Q&A document, and I will do some research about it. I don't remember off the top of my head what those rules are.
Okay. MIOSHA Rules for healthcare says masks must be worn regardless of vaccination status where there may be patients. How does this work in a CCRC setting? A patient may go to other areas on campus like billing offices, but it is not typically a patient area. Do those vaccinated staff have to wear masks?
Well, how to think about this? I think that it needs to be confined to resident care areas. So when staff are in resident care areas, they must wear source control. They have to keep social distancing whenever possible. I think that non-residential care areas, so outside of your HFA, AFC, and nursing home and a CCRC campus, that's not a residential care area. So if your residents are moving, which I believe is what you alluded to, they should probably be, if they're fully vaccinated, I think the MIOSHA rules for general public visiting, for lack of a better word, public movement, being in public. If they went out to a grocery store or if they went out to a restaurant, the public rules apply. The residential care rules do not apply. So I would think about where are you at? And if you're in the residential care setting, you have to apply the residential care rules. If you're outside of those settings, then the other rules for masking and gathering in the governor's most recent epidemic order, those would apply. That's the way I have considered it for the last month or two. I believe that that is the intention of the department's guidance.
Oh, okay. With the new guidance for group activities and visitation, does this mean that we can initiate a religious service if there is only 1 or 2 people coming in from the church synagogue to perform the service?
Yes, I see nothing that precludes you from doing that. As long as you remember, you have to look at vaccination status of everybody who's coming in the room to figure out what source control and social distancing is required. But yes, you can do that.
When in outbreak testing, can communal dining and group activities happen for those not in quarantine?
Yes, I don't see anything in guidance that precludes that as long as they're not in quarantine. So it depends on where your affected area is. It is possible that maybe if the dining room wasn't incorporated in your affected area, you would not be able to do that. But it depends on the situation. And if indeed that dining area is outside of your affected area, you can certainly continue to have communal activities.
Are outside visits allowed to be longer than 30 minutes?
I don't believe that there's any requirement at all about the time of a visit. I think at one point there was an expectation that the facility could limit the time, duration, frequency of visits based on managing, having all of those external people in the building at one time and the risk to the residents. But there is no requirement to how long a visit can be. You just need to set a policy and apply it consistently that meets the needs of the residents in your facility and their safety.
Are you saying we are no longer required to limit visitors to 2 per resident, limit flow through the building, log visitors, and require they make an appointment to visit, etc.? Or should we still be doing this as it is still recommended?
Except for one of those things, if I heard them all correctly, are considered best practices by the state, and they're not in the CMS guidance, however, except for the part where you have to limit the flow of visitors through your building, and that they should be confined to only places where they have to be, and still using specific entrances, etc. That's still in the CDC guidance. The rest of that is kind of fallen to the wayside. MDHHS recommends it as a best practice. However, facilities are not required to do it. So I would look at your own facility and determine, what the safety risks are, and make a determination for those things as you wish. However, the visitor flow, that still has to be managed.
Okay. If the state says all residents must be 6 feet apart, if any in the room are unvaccinated, does this apply to dining? We have been allowing fully vaccinated residents to sit together at one table. Those not vaccinated who come to dining room sit 6 feet apart from anyone else. Do we have to go back to having everyone sit 6 feet apart from each other? So essentially one person per table?
Technically, according to the MDHHS rule, yes, you do have to do that. I guess, I'll be honest with you, I think it doesn't make a lot of sense to me to further isolate people when you have an option for vaccinated people to sit together. But that's not what the state is saying. I think the state is a little bit worried about the stigma to some people being able to sit together and some people not being able to sit together. And I do kind of get that as well. To me, except for, medical contraindications, it could be an incentive to get all of your residents vaccinated. But technically, according to MDHHS, you have to separate everyone if there's anyone in the area who's unvaccinated. CMS and CDC, though, say you can cohort your people if you chose to, by putting your vaccinated persons maybe in one dining set, and you could put your unvaccinated persons in another. That might get around some of that, but that's also logistically difficult. So, but again, technically MDHHS is telling you can't do that.
Is there a limit recommendation for outdoor visitors or an age limit for indoor visits?
No, there are no age limits. The only age limits in terms of children in the facility is whether or not they have to wear a mask. There are no limits to visitors at all at this point, except the state recommends 2 at a time, but that is their best practice guidance, not their requirements. And there's certainly no limit to the number of visitors that you can have out of doors anymore.
Okay. Not COVID related, but will Leading Age be providing the required implicit bias training that is now required for health professionals?
Well, this just came out yesterday, and as a team, I at least have not been in any conversations about that, but I cannot imagine that we wouldn't. I would think that we would be on that. We have a year to get it together. I'm sure that we will be doing that.
We actually have an education meeting in about 3 hours, so I'm sure we'll be talking about it there.
Okay.
Oh, okay. Updated guidance says masks must be, it's all right, it just dropped down. Okay. Updated guidance says masks must be worn except in certain situations. One of those is unless participating in a religious service. So if they are at church, they can unmask even if unvaccinated, or do we think this is meant to be for a one-on-one religious interaction like communion?
I would have to look at what you're referencing. I have read that those same words before, but I don't remember where they came from. But in my head, that's for religious services outside of a residential care facility. If you're having a residential service inside your care facility, you have to apply all of the normal group or communal activity rules. Hopefully that helps.
If there's a group activity going on and everyone is vaccinated, but an unvaccinated person wanders in, you have to stop, put a mask on everyone, and move them 6 feet apart?
Well, my first inclination would be to redirect the person who's wandering in to someplace else and go from there, depending on the situation. But if you do have someone who comes in and remains there, you do have to, and they're unvaccinated, the rule says you have to mask and potentially socially distance yourselves. In Michigan, saying you have to socially distance everybody, but the CDC is saying only the unvaccinated people.
Okay. Looks like that was the last question for now, so we can move on.
Okay, all right. So the next section's about the Equal Employment Opportunity Commission. Because last Friday they updated their FAQs and along with some other documents about issues related to COVID. So if you haven't looked at this, HR teams might want to review it. It has a lot of questions and answers here about how to think about the EEOC rules as they relate to COVID. So there's 2 links on the page. One is to the entire set of materials that they put together for COVID, and the other is the pandemic preparedness guidance for the workplace. So we pulled out a few of the responses to the FAQ document just to review here. I want to put out a disclaimer up front that I'm not an HR expert, but I thought it would be good to review a few of these provisions. Some are well known at this point, but the state of being in a pandemic emergency allows employers to do some things that they normally would not be able to do, such as require screening and ask questions related to some health information during that screening. But one of the things you can't do is you cannot single out a particular person for screening from everyone else, unless there's some objective evidence that there's some disease or infection going on related to COVID. You can require a physician note to return to work. You can require COVID testing of any staff before coming into the facility if you need to. But you can't require an antibody test before allowing the staff to return to work. And at first I didn't understand that, but I think perhaps what this is about is if a staff calls off with COVID, you can't require them to take an antibody test to see if they had COVID before allowing them to come back to work. You also cannot ask if family members have had COVID or any particular disease, or if family members of staff have been tested. But you can ask staff about any close contacts with persons with COVID. You can move it, Blake, yeah. So some other provisions. You can bar anyone from being on site if they refuse screening. You can ask about what kinds of symptoms someone has when they call in sick. And in fact, you've always been able to do that for infection control purposes. You can ask about any travel, any possible exposures during travel. And you can do that at any time, really, technically, because the EEOC says that that's not a disability-related issue. You can collect and store this personal medical information, but it has to be in a separate file, and it cannot be in the employee's personnel file. You, of course, can disclose the name of a positive person to any public authorities. If an employee is positive, and we got a lot of questions about this early in the pandemic, you have to tell some people who that person is, but you have to limit the number of persons who know who that person might be to those staff who would be absolutely necessary to know. And when doing contact tracing with your frontline staff, you can only provide information about potential contacts, but you can't relay that person's name. So if you have a staff in the kitchen who turns up positive, you would identify from that person who they may have had contacts with, but you would, for the rest of the staff in the kitchen, you would simply let them know that someone in the kitchen has turned positive. Employees, though, can communicate to the administration any information they may have about a coworker who appears to be symptomatic. They are required to actually report that. I'm sorry, can you go back a bit? There's some other things here at the bottom about confidentiality. Those medical records that we were talking about earlier, that electronic confidential information can't be housed where anyone else has access, and that would be something that we would know normally anyway. You can tell a worker that a coworker might be teleworking, but if they're teleworking because they have COVID, you can't communicate the reason for that. Okay, you can move it now. So what are some of the other things you can do? You can obviously screen applicants, take temperatures. You can delay the start date for a new employee who might have symptoms. You can withdraw offers for a COVID positive person if you find out later that they're positive. But what you can't do is you can't postpone a start date or withdraw an offer just because someone is 65, over 65 or pregnant, meaning that they would be at higher risk for COVID. You can't do that. That would be against the EEOC. For people who are at high risk, such as persons over 65 who might be working for you, you do have to consider accommodations to eliminate or mitigate possible exposure to persons who are at high risk. As long as that work doesn't create undue hardship. Employees are not entitled to accommodation to avoid exposing a high-risk family member. So if you have a staff person who has a 90-year-old mother at home, there is no accommodation that has to be provided to them for that risk. You can, and this is the piece that really, there were a lot of updates in these FAQs, but this is the primary one, that employers may mandate vaccination. But at the same time, employers must provide reasonable accommodations for anyone who chooses not to take the vaccination because of a disability or because of a sincerely held religious belief. You cannot treat employees differently based on disability, race, color, etc. In other words, you can't require vaccination of persons who are all Hispanic or something like that. You have to treat everyone pretty much the same way. And some reasonable accommodations might be requiring face masks, social distancing, modified shift times, telework, etc., for people who might be at high risk. So the MIOSHA Emergency Preparedness Order was also updated again, and it is continues to be actually effective through October 14th of this year. There are some changes here. Most of them do not really apply to residential care facilities. You still have to have a written preparedness plan consistent with the MIOSHA guidelines. Workers are still asked to maintain social distancing in general whenever it's feasible and they're on the work premises. Employers must still provide non-medical face coverings. Remember, this is for general work, not necessarily residential care, except they don't have to provide face coverings for vaccinated employees. Again, that does not apply to nursing homes and assisted living level care. If a person is not vaccinated, they still have to keep a social distance of 6 feet when indoors. One of the things that they do say that all staff have to wear masks if they're in a patient area. You have to keep records of who's fully vaccinated, and that allows you to identify who can be excluded from some of the rules. But one thing that they do say is that employers have the ability to continue to require face coverings and social distancing, regardless of vaccination status if they choose. And we also know that one of the most important pieces here was that remote work is no longer required for those who don't have to come on site to do their job. And there's a bit of an update in the language for cleaning and in some of the definitions. Well, we just want to remind everyone that MIOSHA rules apply to all workplaces, although there are often more restrictive regulations for healthcare facilities. But the MIOSHA rules and the MDHS masks and gathering rules apply to independent living settings in Michigan. Remember that any vaccinated staff in healthcare facilities who do not come within the vicinity of patients or residents, they don't have to wear a mask. So here's our slide about volunteers. We got a direct response finally from MDHHS. They've made it clear that facilities have discretion on how to proceed with any of their volunteer programs. There is, of course, the caveat that volunteers have to continue to comply with core principles. Any testing required for staff also applies to them. Their vaccination status must also be documented and known and included in the weekly NHSN reporting. The Michigan Long-Term Care Ombudsman Office also issued updated guidance for their staff visits last week. Their visits no longer have to be pre-scheduled, restricted or based on county risk level. They are going to be resuming in-person visits. One of their requirements is that their staff does have to review all of the COVID resources and guidance that they included in the update, and they have to attest to those to have done that. The link to the full guidance is here, and within that is the link to all the resources that their staff have to be aware of and familiar with prior to making on-site visits. The FDA also recently issued new information on the use of NIOSH approved and unapproved respirators. Since respirators are not considered to be in short supply any longer, there should be no facilities using any crisis strategies, and they should be resuming conventional use practices at this point. The approved list of respirators approved by NIOSH is linked within the letter from the FDA. The facilities should not be purchasing non-approved respirators if they're looking for respiratory protection. In other words, if you're caring for someone who is in quarantine or in transmission-based precautions, you must use a NIOSH approved respirator. So you should not be purchasing any non-approved respirators for that purpose. Any non-NIOSH approved respirators that you have at this point should only be used for source control. So that means for patients who are residents who are not COVID positive or in quarantine and are not carrying any risk for the disease. Any respirators that have been decontaminated and reused as part of mitigation strategies must be discarded at this point. And then there's a long list of updated documents to help you understand what's going on with the respirator requirements. And those are all here on the webpage, not webpage, I'm sorry, slide. So that ends our webinar for today. Let's see if there's any final questions, Blake.
All right, thank you, Deanna. We just have a couple more, so I will hop right into those. Can we require service providers be vaccinated like hospice workers?
I would have to defer to some legal experts on that one. I do believe that in many cases, you are allowed to mandate the vaccine for staff, considering that if you are contracting with service providers outside of the agency, you may well be able to do that as well. However, let's say a physician comes in that is, and this is, an example, could be anybody, that is someone who is engaged by a resident or some other service provider that isn't necessarily related to your relationship with them, maybe related more to the resident. I'm not sure if you can do that. And I'm just spinning this off the top of my head. We will take this question from our Q&A and send it to some of our legal friends and see what they say about that. I really don't know the answer.
Does the requirement to keep records of staff vaccination apply only to nursing homes, assisted living, etc.? Does it apply to independent living, HUD, affordable housing?
I believe that you do have to know the vaccination status of everyone, no matter what your provider type. And my understanding is you have to keep information about that in your screening logs for at least 6 months. I would think you'd want to keep your vaccination status information longer than that. But if memory serves, if you look at the MIOSHA guidance for regular workplaces, if you don't know the vaccination status, then you have to go back to masking and distancing throughout your entire workplace. So I think that there is a requirement for that. You certainly couldn't use any of the flexibilities without knowing that.
It says employers must provide non-medical face coverings to employees. Would this mean healthcare workers could wear cloth masks? Obviously would wear medical grade for patient care and N95 for PUI/positive.
No, it does not mean that. That line or provision in the MIOSHA guidance is not for healthcare facilities. At a minimum, staff in resident, actually in the facility, have to have at least a surgical grade mask.
Okay. We are still using KN95s for unvaccinated visitors, and with proof of a vaccination, allow a surgical mask. Came from IPRAT recommendations. I had a family member threaten to sue due to discrimination. What are your thoughts?
Can you repeat that again, Blake, please?
Yep, no problem. We are still using KN95 for unvaccinated visitors, and with proof of vaccination allow a surgical mask. Came from IPRAT recommendations. I had a family member threaten to sue due to discrimination. What are your thoughts?
Well, I'm not sure about what kind of discrimination is being considered by a family member. If it's a difference in mask wearing, I think that pretty much the KN95 is, some of them have been approved, some of them were not approved by NIOSH, and a while back MIOSHA did not allow any KN95s for actual COVID care. But the FDA guidance from this past week identifies that those non-NIOSH approved masks can be used for source control. Obviously, surgical face masks can be used for source control. I don't think that there's any rules that preclude this. I think that if you are making a determination of what's better for vaccinated, unvaccinated persons, that's a policy that I don't know why you couldn't apply if you wanted to. I really don't know if using a KN95 for higher level protection is helpful if it's not a NIOSH approved mask. That would be up to you. However, you know, a family member can try to sue you over just about anything they want. So I don't know if you have legal standing. I don't know if they would have a legal argument, let me reframe that. But at the same time, I think that you do have the right to set your own policies, and I don't think there's anything that precludes you from doing that for persons who obviously are not in quarantine and not in isolation, where you would need a full approved N95 mask at this point.
Okay. We were told visitors can wear cloth masks, so why would IPRAT make that recommendation? We are not making I'm sorry, it moved yet again. We are not making a difference between them and not asking about vaccination for visitors. We provide them with visitor guidance that states if they are unvaccinated, they must wear a mask during visit, and if vaccinated and resident is too, they can unmask in the room.
Okay, well, there's a lot packed in there, so let me try to get to it. First of all, the IPRAT team often cites best practice as opposed to what the actual requirement is. And so if they make a recommendation that you do that, that is only a recommendation. It is true that visitors only have to wear a cloth mask. If you choose to have unvaccinated visitors wear a higher level mask, I suppose you can do that. But again, that is that's only a recommendation. I don't think that anyone, you're not mandated to do that at all. And that's what I think is a little difficult about some of the guidance that comes out of the state. They're not on the front line with you guys. They don't understand the nuances of some of the rules. And sometimes I just don't think that they have the experience to understand the difficulties in applying some of their best practices. But there's nothing in the rules that says that you have to do that in any way, shape, or form. You only have to make sure that visitors have a cloth mask. Now, the question I thought was whether or not you could require someone legally to do that. And I think you probably can. You can make your own facility practices. Do they have a right to sue you? I'm assuming this is the same person I'm talking to as the previous question. Well, they can always try to sue you. I don't think they would have much of a legal issue, though, really. And if that doesn't answer your question, please shoot me an email and we can talk more.
All right, with that, that appears to be our last question. So if you do think of anything after the webinar has concluded, as always, you can email safeandcalm, Dalton or Deanna at leadingagemi.org, and we make sure to get any of your questions answered. I did forget to mention earlier, so I will mention it now. We do have the handouts in the tab right now, so you can go ahead and click on that and download those in case you did want those. So now with this, we would like to thank Deanna and Dalton, and we would also like to thank the 85 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. With that, our next webinar will be in 2 weeks, so I believe that would be June 16th. So we hope everyone has a great remainder of their Wednesday. I hope you have a great remainder of your week, and we will see you all again on June 16th. Thank you and have a great day.
Bye, everyone.
Take care.